Good evening, and welcome to the Henry Schein Dental Academy webinar series. My name is Corinne, and I will be your moderator. We are excited to welcome Dr. Scott Strommer, practicing dentist, lecturer, and clinical instructor at the prestigious Coy Center in Seattle, Washington, as our speaker tonight. He will share best practices for diagnosis and treatment planning, along with a case review. Before we get started, we do have a few reminders for you. At any point during the webinar, if you have questions, please type them into the Q&A section of your control panel, and we will answer them live at the end. Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand, and this webinar is sponsored by Dentsply Sirona. Dr. Strommer, welcome, and thank you for being with us tonight.
Thanks, Corinne. Thanks, everybody, for joining. Appreciate this opportunity. It's something that it's made me a better dentist. I'm passionate about, and it's always great to share, what we have with others, and gives you a chance to actually grow along the way. So I appreciate the opportunity. I wanted to just go through some of the things that I've been doing with respect to digital technology, and I'm not going to be talking about just individual teeth tonight. I'll be talking about a more comprehensive approach, and the title here is Full Mouth Reconstructions, digitally led strategies and applications, like the title slide says. So as we're going through this, just keeping that in mind, I'm more than happy. We're going to save any questions or comments till the end, if that's all right. Corinne, you can manage that for us, and we'll address that at the end of the program. So I practice in San Diego with my wife. We have a wonderful practice on the island of Coronado, and we have another practice in Mission Valley. And one day, kind of late last fall, I just walked out and said, "Oh, what a gorgeous day. This is one of those just iconic sunsets." And I walked down to the beach a few, not even 3 blocks down, and just took a picture of this with my phone. And I don't know, for some reason, it just makes me smile seeing that. A little background on us: we have 2 practices. This is my wife, Leslie, and I. We've been practicing and been together for 30 years. That's our Coronado practice in the upper left-hand corner. The lower right-hand corner is an interior picture of our practice in Mission Valley. That's the 2 of us on the lower left. And on the upper right is a picture, I think it's a couple years ago now, of our family. That's our 2 boys. Our youngest son on the right there next to me is actually our practice manager, and he helps practice. He manages both of our practices. I've been using CEREC technology since the Red Cam. So it's 20 years now. I'm so thankful that we're in a whole new level of intraoral scanning now, and the Prime Scan is absolutely a game changer. Those of you that have it know that, and those of you that have used it, you know how simple and easy that is compared to what it used to be. We actually are part of a bigger group of practices called Aspire Dental. We joined 9 months ago. And it's part of, we're part of 19 practices now in 4 different states. That's not what this is about, but like this community here, it's always great to be a part of something bigger than us. We can lean on people and learn from, and we just got back from our all hands meeting this past weekend in Denver for Aspire Dental. So back to the lecture. Tonight, I'm gonna make sure we hit on some really take-home goals. These are the things that I found to be very helpful with getting through these bigger cases. So one is dental facial analysis. Where are we now with the patient? Where are we going? Obviously, that'll be part of the treatment planning. And one of the things that we use is facially related tooth position and treatment planning. It's a really step-by-step approach. We'll go through some specific prescriptions to communicate with your lab technicians. They will greatly appreciate that. I know many of you, or somebody, I don't know how many do their own lab work, but somebody's got to be able to execute the plan for us. And it's always nice to almost have a recipe, so we're not making things up as we go along. This is going to be also addressing simple and predictable, digital face pose and centric relation records. This is an area that, if you're doing cases like this, you're going to have to set the case up correctly with your face bow, and then how are you going to manage your vertical, whether it's going to be, with a CR record or myofunctional. That doesn't matter per se in this presentation, but you have to have a way to do it. I happen to be using the centric relation record. John Coyce has helped me with that. Of course, we're using the Dentsply Sirona Prime Scan for intraoral scanning. And once we start getting into this next area, it's really about the design and the execution. And for those of you that are doing it, you'll be using some software, whether it's the chairside software that you have in your system for the Prime Scan. That'll be the CEREC chairside. Otherwise, you can use other softwares. I happen to, on this case, be using Dentsply Sirona has an in-lab software. For me, it's a little more powerful. It allows me to work on a big screen at my design station. And from that, somebody's doing the wax up, somebody's got to design the restorations, and somebody's going to have to, just take care of all of that procedural. For me, that's part of my just passion for these, is doing my own work. So whether you do it or not, somebody has to. So it's still going to require us to have a system. Our patient tonight is going to be Eric. So Eric's 57 years old. He wants to fix his smile. We're going to gather some data like everybody does. And really, when we collect our data, the next thing we have to do is interpret, right? That's a risk assessment. So medically, we do that. We all have a medical history form. Eric is low risk, ASA1. I think at this point, dentistry, we can get better at having real metrics with respect to, okay, how healthy are they? What do you mean they're healthy? So we can speak like this. ASA1, how about periodontally? Well, Eric's low risk. He has stage 1 periodontitis, and it's grade B. So he's 57 years old. That's a low risk category. Biomechanically is a category we use for teeth. And for Eric, this is the area that really needs the most support for him and where he's going to need the help. He's a moderate risk, or yellow dot, we call it. He has acid reflux, gastroesophageal reflux disease. He's got abrasion. He has gross decay on his lower right first molar and multiple structurally compromised teeth. Functionally, Eric actually has acceptable function. I'll go through this. This is all part of, trying to set these cases up correctly. But if you know what your patient's risks are on the front end, you know what you're taking on, it'll make your life so much easier. Aesthetically or dentofacially, he's a high risk patient, meaning Eric, his lips aren't, you'll see later, moving and showing tons of gummy display, but there's enough display, and the fact that he wants to change and fix his smile, he can't do that on his own. So he's moderate, or in this case, I put high risk. For sure, he has a really poor prognosis of getting this fixed on his own, as you'll see. Saw Eric about 12 years ago when he finally got photos on him in 2011, and that's how Eric presented. He came back at this time when I saw him. He's obviously younger, nothing's hurting, and there wasn't a lot of motivation for him to move forward with taking care of anything. So we all have patients, we all have an Eric in our practice, right? It's almost like it's not bad enough. And so he came back. And of course, maybe to share with you, you can see how we've got some changes in his dentition over the last 11 years or so here. Now he's got a son that's getting married. He's got some big events coming up. And even some family members are saying, it's okay, let's get this fixed. And he's finally ready. It didn't happen to be any precipitating event other than, you'll see later, there's a tooth that's decaying, and he's kind of got a bad taste coming from that. So appreciate on Eric, as we take these photos, really, I don't know if my pointer shows up. Corinne, does this show up on the screen?
Yes, it does. Yep.
Perfect. So just this subtlety of, you can see up here for Eric, these areas of abrasion, and then in here where the enamel's been breached. and then start looking at it 10, 11 years later, how it's smoothed off. And even this enamel, you'll see on some of the closer up views, even the enamel is going through the abrasion process, not just on the dentin. So having these subtle changes, gives us a sense of the activity of this disease process, what's going on. It helped me prepare his case. And I think it's also nice showing Eric where he was and where he's at. Everybody, likes seeing, say, your own blood work and your markers going down and getting better. And when we do this with some of our patients, we have an opportunity to show them that, this is active. This is not stable. Just one final view here. You can appreciate even on these areas in the incisals where this is how much enamel had been breached, and we have the dentin exposure here. And then we come over here, you can already see it's just expanding. Everything's deeper, more pronounced as we're going through. So here's our basic photography. We're going through the case. And we always, when we get into what's going to ultimately be a new smile for someone, it's nice to ask them, how did you get this way? You weren't born like this. What happened? Many patients know, and most of them have some idea, but they're not really sure. So a great thing to have is for them to bring in a historical photo. It's usually going to be a graduation, a wedding, something like that. And then letting them know, and some will come in and even tell you on the front end, I want my old smile back. I used to have a great smile. So I've learned from John, to ask the question, are we building you a smile that you used to have, or is this a smile you never had? And certainly if it's a smile they used to have, you better have them bring a picture in, or they're going to bring it in right when you're getting ready to deliver the case, and that's already too late. So I want to acknowledge John, the Coy Center. I actually started up at the Coy Center right at the time when I got my first CEREC system. So it's been a great journey. I now think CEREC and I think Coyce, and it's been an awesome journey for me. I've gone through the whole curriculum, and I want to just take a minute here to acknowledge John and his systems. And what I have now, with the Prime Scan and our Prime Mill and the materials that we have today, I can apply and use all those principles with this great technology that I've been using for, 20 years now. Happen to be a clinical instructor up at the Coy Center too. So I don't have any real original thoughts here. I'm just copying those people that came before me, and I happen to be a disciple of John and those other people up at the Coy Center. Maybe some of you are on the webinar tonight. So having said that, if you're interested in that, this isn't a part of this, but having somebody that's evidence-based and has a system for us to follow, not just to go up and watch people show beautiful cases, and yeah, that's great, but to be able to take it back into our practice and implement it and integrate it, that's my passion. I've done lots of trainings for other dentists, and it's a whole different level of learning when you start applying it. And John really has helped me with that. So back to Eric. Like everybody, we've got a medical history, we've got a dental history, and hopefully we're using these to assess the risk and kind of like allow us to pump the brakes before we go rushing in on some of these cases. There's lots of co-risk factors and comorbidities, and hopefully you've got a system in place that'll allow you to assess that before you get started. In this case, this happens to be a just quick synopsis of what I already showed you. Eric has, he's low risk periodontally, biomechanically, he has some moderate risk, functionally, he has low risk, and dentofacially, nothing's going to change without our help. So let me put it this way. I didn't always have a system, and maybe some of you have been in this situation too, and you start winging it. And I think you just have to be around long enough to wing it enough times that when you start realizing, wow, I didn't think that was going to work out and it was super easy, or I thought this was going to be super easy, and it's that case that you're following for a year and a half and you still can't figure out why it went sideways. So my point is, having a system is that thing that we do to give us a predictable result. And then we're always working on our systems. We're trying to refine them and become more efficient and effective. And when we do that, I find that, we have more joy. We can be more profitable in our businesses. Maybe you can help more people. So the system is really the floor. It's the foundation. It doesn't set like this, the top bar for us. And so my system happens to be coming from, as you've already heard. So having something where I can go through 10 steps and be able to manage everybody's case the same, make sure I don't miss anything, has been peace of mind, I guess is how I would put it. I don't have to do this. We don't have to do this on somebody that needs a prophy and maybe some whitening and a buccal pit. But when you start getting into some of these larger interdisciplinary cases, you want to make sure that you know where you're at and you know where you're going. So here's what we use. It's all about, finding out where we want the teeth in the face, how are we going to manage the function of this case. Aesthetically, we want it to be pleasing. And then it has, after all, this is a chewing system. We got to make sure this chewing system works. So are we going to use CR? Are we going to use MIP? Is it going to be a neuromuscular approach? What's the status of the joints? All of these things need to be taken into account when we're going through these cases. So back to having a system. Eric, I've already brought up his status here. And so just a quick slide on that. As we go through these cases, many of us like to do our own work and many of us don't. So if you're not going to be doing this on your own, you need to have laboratory support. And there's lots of them out there. All I'm doing is showing an example of mine when there's something that either I don't know how to do, don't want to do, too tedious, or they're better at it. With an awesome scan from the Prime Scan, some nice digital photography, and at the push of a button, we have a digital lab available to us to give us back whatever we might need, whether it's the restoration itself, whether it's a digital design. You can appreciate how this whole area has exploded over the last few years. And it's something that I lean on a lot to help me with my cases. So in this case, we're going to use something called some dental facial reference glasses. This is all about having the patients use these glasses with some photography, and then we'll throw in a nice scan with our Prime Scan, and I'll be able to get lots of data and information that used to be really tedious to get. So these glasses, I don't quite have enough time to go into it, but it's about natural head posture. We put these on, you can see these actual little black and white markers here. They have a distance between them. When those are in place and we have a nice SLR photo of the patient, we can come up with some really nice data. These fins are used to be leveled in the face, so we can make sure that the twist and the tilt and the tip of the head has been managed. All those things that I'm sure many of us didn't enjoy doing when we're trying to take a face bow, and they always came back mounted steep like this. When we end up doing our smile designs, we want these to fit in the patient's face. And this just happens to be one of the easier ways I've found to do this. And I can thank John for this. It's been something that we love using. From there, once again, we've taken a scan, we've taken some photos, and we pushed a button. We can get as much support from the laboratory as we want now that we have this natural head posture captured, and doing a digital face bow and bringing it back. I'm still, you're going to see in the presentation tonight that I still find that I have to go back to my articulator to make sure it's a double check of this natural head posture and that it's flat. We call it flat on the platform. You'll see that coming up later. Yes, most of the digital design softwares have virtual articulators built into them, and they're getting better and better. The challenge is, unless you know where that fits in the patient's face, relative to the horizon, you start, doing a 14 unit case, a full arch, and it's game over if you've got a slant left to right, or the AP is off, or the midline's got a twist to it. So what these glasses, this happens to be the version just before this set of glasses. The new set came out this past summer. This allows us, with some photography and a scan, to line this up with our laboratory, and you can see how everything is superimposed, and we get back this. So this here platform, I'll call this step one. I want this to be my maxillary incisal edge position. I want this digital face bow to be based on natural head position. And now I can move forward from there. These are all the little things, subtle things that, in my system, I don't have to think about it anymore. But if you don't have a system, you've done your mock-up, and it comes off a little bit of a can, and then you're spending all this time either redoing it, you're trying to add in the mouth, or recontour in the mouth, or both. I'm pointing fingers at my lab's blaming me, saying this is the data you gave me. This is a way to avoid all that and be able to do these predictably from the beginning. So you can see down the old school way, having to do a manual face bow is no longer necessary, at least for me, right? And there's some things you need to get. For my system, it's with Panadent. That's not what this is about, but want us to be able to get a digitally mounted case. So we're going through on this. Here's Eric. Here's what I love. Now I've got some data. And from that photo with those glasses on, and I have Eric do, really it's 3 different smiles. One is a repose. One's kind of the nice smile, and the other one we call it Schein, and it's maximum lip dynamics. That, coupled with those markers on the glasses, now I know how long Eric's teeth are. I know how wide Eric's teeth are. I see how they are in his face. And I'm going to figure out where are we and where are we going. I got to figure out how to put this guy back together. Push of a button. You might do this yourself with some kind of mock-ups with Adobe, all sorts of things available, software, apps, labs. I love, for 20 bucks or so, I send this to the lab and I say, hey, make Eric look pretty by just giving me a mock-up for his upper 6 teeth. This comes back. I can share this with Eric. I don't have to do the emotional mock-up in the mouth anymore. I can share it with him this way. It works great for virtual case presentations, things like that. Here's the upper 6 teeth only. Once again, just from some photography. Shows where before, what it would look like afterwards on just a simulation here. This is for all of the teeth. So comparing, Eric, what do you think? We can make you look good this way or this way. And it just, what I found with these is it really gives the patient some buy-in on where they're at, where we could go, what the potential is. And even if your patients don't say yes right away, most of them want this. They're just going to have to find a way to fit it into their lifestyle, their budget, timing, things like that. Luckily, Eric had already been worked up for this years ago, and he was ready. So now, turns out on Eric's case, his vertical dimension is going to have to be changed. I happen to use something called a deprogrammer, a Coista programmer. Those of you that use maybe a Lucia jig, or you've used the leaf gauge, there's neuromuscular approach. For me, I'm gonna do a Coista programmer. His joints are healthy, and I can do a centric relation record. It's pretty predictable. I'm not gonna have time to go through how we use this with our patients, but this is what it looks like in place. They have to wear that, and it allows us to have a passive seating of the joint. And then the patient wears this for a period of time. They come back, and we're going to take a centric relation, jaw relation record, and then mount our case up. I already have his upper jaw mounted, right, digitally from just some photography and a scan, and I send it off to the lab. I'm now going to do a jaw relation record and mount his lower arch. So as we work our cases up, I don't know what everybody else's system is, but what I found, thanks to John, and this is actually Carl Misch's article, is about finding out where the incisal edges should be. Some of us will use the central incisors. Some of us, you'll see in this example, I'm going to recommend using the canine and trying to use something that's going to work always. Like you want everybody to benefit and be able to use your system on. You don't want to have a system for, one situation, another one for another. This situation, if you see on the left here, it shows this distribution of data. I just want to go through this quickly. Is much broader than this range right here. And then over here for males, the same thing. And the point is this: when somebody is saying Emma and they have a repose picture, the canine should be at 0, meaning it's not too negative and not too positive. And in this example, the population we use, everybody was represented between -2 to +2. Whereas if you're using the central incisor and some of these other ways of trying to determine where the teeth go in the face, people that do a lot of dentures, you get really good at this and you'll start realizing this is where you want to start with the cuspid is at 0. And we're going to go back to our photos with Eric and notice that he's actually at almost 2 millimeters at repose. So if we're going to put him in center of the bell curve here, we should think about bringing his canines down to that. Here's where he starts. These are his examples of his teeth right here. He's only 7.4 millimeters long, right? He's 6.8 millimeters long, and a normal tooth length for central incisors is about 10. So we're going to go for center of the bell curve and try to give Eric some teeth that are 10 millimeters long, 8.5 millimeters wide, and that they are in the right position in his face. This is all coming once again from just some photos and some scans. So now that I have this, right? This is where, if you're not doing your own work, you push a button and you tell your technician, this is where I want the canine. I want it to be 2 millimeters down from where it is existing on that number 6, level it across the arch. I want it to be level left to right, front to back. I'd like the central incisors to be 10 millimeters long, 8.5 millimeters wide. And whether you do it yourself or somebody else is doing it, it has to be communicated. If not, this is where we have those. We've all had cases where it didn't go the first time, and you're coming back and you say, "Oh yeah, I need to add this. I didn't do that." These are the parts that I find really, really important. So as you can see here, these are these not natural, but the center of the bell curve measurements. Here's what we're going for Eric's case on the front end. And if you can see, this is pretty cool. I don't have to really do much removal of tooth structure. I'm already getting a good feel for this. We're just going to add back what he already took away. So we've got facially related tooth position, and we're going to do our digital wax up. This is using the in-lab software. It can be done in the CEREC chair side. I just find that when I'm doing, these aren't cases I'm doing same day. If I'm going to be doing it after hours or in between patients, I'd rather be sitting on a bigger computer at a design station. That's how I like to do it. And the Dentsply Sirona in-lab software is very similar to the chair side, much more powerful. You can get as deep as you want on this, but I just wanted to give you an example of, and I'm by no means a master of this, but this is pretty quick and easy to do, just drawing some lines and getting some proposals. So here's the wax up. You can see our dimensions. We're following our recipe, or your technician could be following the recipe for you. Here we are, ideally, tooth position and dimensions are planned. And then it's really neat in this software, I can virtually cement this wax up and it creates a whole new model. So this software goes in layers, and the lab technicians out there, anybody that's done this, appreciate it. This is how the lab does it for you. Or back when we still use wax, you would just be waxing this up and you'd have to take a dupe of that. In Eric's case, it's good to mention this now, that his new vertical dimension is going to be managed by the upper arch. So we're bringing the upper arch down, we're making it longer in his face, and that's what's going to open his bite. We call that step 1 and step 2. Step 1 being the maxillary incisal edge, and step 2 being the maxillary posterior occlusal plane. just a quick example off of a putty stent. Eric's obviously not going to need to have a lot of incisal reduction on his case. And for those of you that have done cases like this is where personally, if I didn't do it this way, I get lost. I end up in these cases having a tendency to over prep or take away more tooth structure than I had to. So just by taking the time, following the recipe, it makes it easier for me chairside. I did this for demonstration. I didn't use it for any other part. It could be used for a prep guide later on, but I'm going to show you how I do that anyways. So from that, we had our virtual wax up. We got a putty stent. You put in your favorite bisacryl. In this case, I use Luxatemp, and we just tried it in with Eric. Patient's not numb. And so once again, we've got our photos, we've got our CAD design, we've got our in-the-face emotional mock-up, if you want to call it here. This is a real trial smile, and it's looking like everything that we've been planning so far, all because of just having the predictability of what we've done up to this point. Excuse me. So remember, Eric was deprogrammed, as we say, and we go ahead and put this in place, and I can spot in his bite right here. This is really, for those of you that do these cases, you're already having a good feeling here. You're looking at this and you're saying, all right, this is going the way we want it. Many of us have done this, and the patient's biting all over the place. We don't know where the jaw wants to go. That's not a fun day. So it's all about starting with the end in mind. And this is puts a smile on my face when I see this. So if we're going to do some ideal preparations, I know that I need about 1.52 millimeters for my incisal reduction in the anterior. In this case, we're going to be using the Emax material. So my point on this is we want to have ideal preparation based on, the type of restoration and the contours of the final crowns. So by having that mock-up in place, I just prepped that ideally. And as you can see, as I'm going through on those, I haven't even touched his teeth yet. So there we are, we're done. I'm going to round some edges and smooth some corners and get some final contours for this so we can have an ideal design. And here is our pre-op, and there's our preps. Those of you that do these, it's I don't know. I love seeing the fact that I get to save all that tooth structure. You can see some of the enamel still, in place. He's already breached the enamel due to that abrasion and some of his other, his GERD and acid reflux, other things that are going on. But it's nice to check and see these things that are going along. Everything's tracking. So let me back up. Of course, we've done our final impression. In this case, I'm using the prime scan. On this case with Eric, I did not retract. I think there was one tooth I had to do retraction, but maybe appreciate the following. My new philosophy is when we're scanning, if you can see it, you can scan it. Remember, we're placing retraction cord, and I would do a 2-cord technique usually if I'm doing a PVS impression, but the cord was for PVS, right? We'd do our primary cord and the second cord on top, leave the fourth cord deep. Now you have the exposed finish line, and then we would squirt in our VPS around there, the light body, the heavy body, and squirts up in and around there. I don't need to do that anymore unless these things are subgingival, and even if they are, I have other ways that I can manage the tissue so that I can still scan it. The scanner for me, Prime Scan, is just phenomenal. I love it. Even if I'm subgingival and I've got some ways to manage my tissue, I don't have to use cord like I did before. So I just wanted to make that point. Here's Eric with his temporaries. So Eric's going to go home. He's going to wear these. He's all equilibrated. He's in CR. He's going to go home. And here's the point. This is the rub. I don't quite have, maybe it's my confidence, maybe it's not there for me, but the virtual articulators and the one built into the in-lab software is great. It's good, but I don't have a way of proving it because everything can be manipulated in the software. I really need those provisionals that I had for Eric to be proven, and we call it putting it down on the platform, as you can see here. So everything's tracking. I know I have my length. I've got my midline on. It's good. It's straight to back, front to back. The AP is level. Everything's down. We're looking good. Here's how the preps look on there. We got this cross mounted. All of the design, and meanwhile, all of the design is just going forward in the software, right? I'm already doing all of the software design. So here's how they look. I've got plenty of room for my restorative material. That's provisionals. That's what the preps are, showing us how much clearance. That's a lot of porcelain. I would have over prepped that if I hadn't prepared appropriately. Using, in this case, the chairside software works great. I'm using the in-lab software here. This is the initial proposal just by copying my temps. We call it biocopy, and these proposals are just spit out like that. We go through the full design, right? This is, I'm not going to spend too much time on this, but the original provisionals, we call that a biocopy, and then the new restorations are done in either the biocopy mode, or you can do it in biogeneric. My point on that is, at least I know how the provisionals are, and those are working. I can use those contours. The design's super easy. Or you tell your technician, copy my provisionals. So check, double check. Here we are, temps, initial proposals and design. And now, those of you that do this, I hope you're doing it because you love it. I've found it's made me a better dentist. I have a whole nother level of ownership of the case. When it comes to delivery, I'm not bragging. It's my deliveries are better than they were. Even when I did really just great, use great lab technicians. A lot of times their restorations fit great, but the occlusion wasn't quite the same. So, you know, I'm always taking my own inventory and making sure I'm giving them what I need, but something just happens when I do my own cases, and maybe there's just less stress on delivery day because I know what it's going to take to make the case be predictable. So if you do your own work, I hope you're enjoying it. If you don't, this is not where you start, right? But you know, with the software that we have, with the prime scan and the initial proposals we get from the machine, you can do it with a little bit of training. And those of you that want to learn that, you can reach out to those of us that are already doing it. That's what this is all about. So here's the case. I will not be using that yellow microfiber again. I just couldn't find my other lab. So I'll click through this quickly here. Corinne, how are we doing on time?
We're doing good. Yeah.
Okay. So we're going through here. These were Emacs HT BL3. I used the HT because, well, one, we had plenty of thickness on these. A lot of times when I have a more traditional cohesive crown and the substrate is less, the HT, for those of you that do a lot of these cases, they can gray out on you. The value can really drop, but this had some good substrate and we're already at a brighter color. So the BL4 on these worked out well with Eric's case. You can see the stain on this. I use actually a rinse. It's by the Carry Free system. I use it because it's got really high alkalinity and it helps the patient's tissues come back nice and tight and healthy. However, what happens is you use this and it kind of clears off the pellicle that can form on teeth, or in this case on the provisionals. And then if the patients are drinking tea or coffee, you can see how much that stain. All he has to do is maybe use a more abrasive toothpaste on this, but I wanted to just point out that that's where that color is coming from. But you'll see Eric's tissue is really tight and healthy. By the way, the provisionals I did on all of these are just shrink wrapped on. I come back and I trim them away with my electric hand piece, fine diamond, and it works out really well. And then we spot the bite in. So things aren't chipping and breaking off. It works out great. So here we are. Temps are off. I'm trying everything in. This isn't really what this is all about. Hopefully you have a system for that. and they're submitted. I apologize, I did not get the final of the uppers only because then Eric came back a week or two later and we did his lowers. I think going through the lowers is not as important as doing the upper, because now Eric's vertical has been managed. I get a prep. This is easy. This is all easy now. We managed everything with the vertical dimension by adding length to the upper teeth. Here we go. So it's nice to see that we planned the upper arch to look like something that was going to be 10 by 8. Sure enough, we were able to achieve it. The ideal proportions that we planned on were 10 by 8.5. It's just, if you really like trying to push yourself in these areas, making sure that I achieve what it was that I was going for is and if I don't, learning from that so that I can communicate with my technician or make sure I make the changes in the future. So now we're going to do the lower. It's the same protocol. I'll go through the virtual wax up with the in-lab software. I'll virtually seat that wax up on itself. I'll print out that model and we'll go forward with the lower arch as you saw already. So here's my lower preps. Most of these are an adhesively retained design. We don't have enamel everywhere, so it's a little bit different than a true enamel-based adhesively retained restoration. But they work out great. And here's our final product. So we have, a nice result. It was predictable. The occlusion's been managed. We have a happy patient. Eric, I didn't spend much time on this, but he lost that lower right first molar. And I believe he's coming in the next week or so to get us started on getting the implant in that lower right area. Here's the proof. Let's really see how the occlusion is. Of course, we know that the occlusion on this tooth has to do with the fact that lower molar is missing. We want to make sure something we call no blue streaks. The red is where we have the centric, and then we use this thicker articulating paper. You have patients chew on it, and you get rid of the blue streaks. If you learn how to do that, you won't have that screeching sound and those patients banging into your restorations or having to do the 2, 3, 4, 5 follow-ups to keep, in effect, doing an equilibration over multiple appointments. So I just wanted to show that. For those of you that are doing cases, you know how important that is. And if you're not doing, big full arch cases like this, hopefully this will help create a system for you and maybe give you the confidence to start taking these on. So there's Eric. There he is before, kind of during and after. And that's it. How do we do?
Awesome.
Early, Corinne. Sorry, I was pushing.
You were right on time. It was actually perfect timing. So we're going to open up the Q&A. If you have any questions, you can please type them into the Q&A section of your control panel. We do have one to start. So the first one reads, do you scan your equilibrated provisionals and send them to the lab to make the finals?
The short answer is yes. And then you would let your technician know, because really it's about the centric stops that you're at, and then they're going to make everything pretty. Obviously, the lab is going to take much more time defining the restorations and putting in the anatomy that you want. So yeah, that's a great point. And yes.
All right, thank you.
That would be your scan that, like we do when we're doing our PVS, right? We would take a PVS of the preps. That's our master cast. You've got your jaw relation record. And then you're going to also, after you get everything done, you put your provisionals on, you'll be taking a impression of your provisionals, probably with alginate and things like that. So when we're doing it in the analog, arena, that's how it goes. And then you would tell them, copy this. And of course, they'll put in maybe stronger line angles and other things like that. But I just want, hope that helps.
Perfect. Thank you. Our next question reads, how has adopting the digital workflow benefited your practice?
Well, one, it gives me much more confidence. Um, I think you can appreciate when you start, when I'm going through these things, there's no hiding. You're looking at your preps, you're looking at your design, you're looking at your finish lines and your results. So maybe I'm taking it all the way to the CAM part, the manufacturing. But even if I'm just doing a digital flow and I'm going to push a button and send it to my lab, whether it's one tooth or 20, I have an opportunity to take a look at it and double check. My point is, it's made me a better dentist. How else has it helped me? There's this wow fact. Not forget, we're working on patients. The ones that have been giving that gross goopy impression down their throat, and now they're coming in and you get to do one or multiple units on them, and there's no provisionals. It's a practice builder. It's interesting here in San Diego, we have a really strong, in this case, CEREC community. So it's almost at the point where if you don't have a CEREC, you're not special if you have one. If you don't have one, you're kind of starting to stand out. That's kind of unique in our region down here.
Awesome. Next question is from Sandy, who says, excellent webinar. Thanks, doctor. And is asking, what is the Sirona model of the machine that produced the crowns that you showed?
I use those crowns were manufactured using the prime mill and an MCXL in extra fine milling mode. So I didn't go into that much on the CAM part, everybody. It probably jumped from nice preps to, wow, all of a sudden there's these purple units sitting on a model. But appreciate if you're doing all this yourself, it takes some time. As you do it more, you get fast at it. But sitting around waiting for these things to mill, that's tedious. So you can, the auxiliaries and the team can plug in blocks in and out. And when we do things like this, the patient's already not here. There's no race. There's no reason to rush through on this. So I'm a big proponent of using the extra fine milling mode. I don't have an opportunity to show you the difference of what it is on regular versus extra fine, but there's a big difference. I did use 2 different milling units for that, just so you know. And I think I showed those at the beginning of the lecture.
Okay, great. Thank you. I think that wraps up our Q&A. We're getting lots of comments coming in, just thanking you for the presentation and for all of the information. So it was definitely a great presentation, Doctor.
That's great. Thanks, everybody. I know we're all busy. It's fun that we get to go online, and looks like there's people from New Jersey. So wow, we didn't have this 15 years ago, right? That's pretty cool.
All right. Well, if anyone does have any outstanding questions, you can always email us at webinars@henryschein.com. Dr. Strommer's email is also on the screen here as well. To view and register for any upcoming webinars, you can go to henryscheindental.com/webinars. And as a thank you for attending, everyone will receive the recording via email in the next week. So thank you all for joining us. Thank you, Dr. Strommer, for the great presentation, and we look forward to seeing you all on future webinars.